So today I'd like to talk about technology and its impact on patient care, but before I begin, I'd like to again thank Fernando and Jerry and Beth and the scientific committee for the invitation. It's been a great honor to be here. And also like to thank the audience. I've been impressed with both your attendance and your attention, both for the morning and the evening, knowing that we have such a great distraction outside. But thank you again. So what I'd like to do is, this is not a scientific talk, so this is really going to, hopefully it's thought-provoking and we'll bring you to another place or where we think the future is going. Fernando already mentioned this report to Air is Human that was reported by the Institute of Medicine in November of 1999, and it was the first manuscript that actually uncovered safety issues within the healthcare arena. And they described 44,000 and 98,000 deaths per year as a result of medical errors at a cost of $17 to $29 billion per year. And what's interesting about this is at a performance level of 99.9%, which we would all say is a reasonable level. However, in two other industries, that would be completely unacceptable. So in the airline industry, 99.9 would mean that you'd have 2 dangerous landings per day at Chicago O'Hare Airport. And in the banking industry, it'd be 32,000 checks incorrectly deducted per hour, completely unacceptable in 2 other industries. What types of errors were they? This is from the report. They were diagnostic, error or delay in diagnosis, failure to act on results, and treatment errors, error in performance, error in drug dosing, and delay in responding to an abnormal test. The locations, as you can imagine, were the high activity areas, intensive care units, operating rooms, and emergency departments. And the report looked into why this was happening. It was a lack of standard credentialing, fragmented healthcare system, lack of access to all information, and human variability. So here's something I'd like to pose as a hypothesis this morning. Medical outcomes is a product of judgment and skill. And so if one improves skill and or judgment, performance and outcome will follow. So how can technology enhance the acquisition of skill? And I'm going to propose that potentially robotics may do that. So we all know the benefits of robotic-assisted surgery. There's improved dexterity, precision, it eliminates tremors, there's improved stability and ergonomics, and it can simplify laparoscopy. I think no one would argue with the fact that robotics has enabled more surgeons to offer minimally invasive surgery. A laparoscopic pyeloplasty is far more challenging than a robotic pyeloplasty. Let me give you an example with a more pertinent example, minimally invasive radical prostatectomy. So interestingly enough, many people don't know, but the first radical prostatectomy was done by Dr. Schulam in 1992. Howard's not here, but he can confirm this for me. And we wrote this up in 1997. He had performed 9 patients, and this is 1992, so it's pretty impressive when you think about it, because the first radical nephrectomy was done in 1991. He had reasonable EBL, pathologic findings were reasonable. You can see that his continence was somewhat acceptable, and he had 4 patients that were potent before surgery, 2 that were potent after surgery. So at that time, one of the issues though, look at his operative times, over 9 hours. What was interesting that people didn't realize, they were able to get the prostate out in an hour. They spent 7 hours doing the anastomosis, and they were doing it transvesically. So, just interesting how the techniques evolved. Pretty much the laparoscopic approach remained dormant for 7 years or so, and it was really resurrected by the French. So Guillenot, Abou, Gaston, they really brought it to the forefront again. And the first robotic prostatectomy was performed in 2000. We all know the adoption curve and where we sit today with respect to robotic prostatectomy versus open. But if you take a snapshot at 2005, 80% were done open, 20% robotic, and they're less than 1% laparoscopic, arguing again for the difficulty in doing a laparoscopic prostatectomy. I've done over 200 to 300. They were extremely difficult compared to using the robot. So robotics has enabled surgeons to perform minimally invasive prostatectomy. Why? Maybe the potential advantages: improved visualization, so you have decreased blood loss, you have magnification, you can obtain a multitude of visual perspectives around the organ. I also believe it's visual rather than tactile. So I think it's easier to replicate because you're following and trying to duplicate what you see visually. I think there's enhanced precision, and it may be an easier transfer of a technique. So is there also the possibility that using a robot versus doing an open prostatectomy, you can decrease surgeon variability? Let's assume that if we looked at open radical prostatectomies, the assumption would be that there's a variability in performance if you look at a high volume referral center and the average urologist after they've gone through the learning curve. There's some delta there. My speculation is that maybe that delta could be decreased if you put in the robot. There's no doubt there's variability in open prostatectomy. Peter Scardino published 2 papers. This was in New England Journal of Medicine in 2002, and basically the summary is, even in the category of high-volume surgeons, we found substantial variation in outcome among individual surgeons after adjustment for hospital volume, case mix. The evidence suggests that these results reflect genuine variations in surgical performance. These are surgeons just at Memorial Sloan Kettering. He didn't make friends when he first arrived. He arrived in about 2001. He also published this paper in the Journal of Urology. He looked at all the data, the outcomes, the margin status of the surgeons at Memorial Sloan Kettering performing prostatectomy. And what he did was he looked at margin status relative to surgeon volume and adjusted for case mix. So if you speculated that volume would improve skill, you would expect this to be a linear line, and it turned out to be a scatter plot. So robotic surgery may provide for improved transferability of the technique and maybe minimize surgeon variability. This is an interesting paper that was published by Jim Hugh in 2012 in European Urology. And what they did was they looked at temporal national trends of minimally invasive and retropubic or open surgery for prostate between 2003 and 2007, and they looked at Medicare sample. This is a population-based retrospective study. The numbers, so it captured almost every Medicare patient between 2003 and 2007. So you had over 19,000 patients who had robotic surgery and over 58,000 who had open. And this just shows utilization of the technique. So the polka dots here, that's the open. The stripes are minimally invasive or robotic. You can see in 2003 it was mainly open, and then you run to 2007, 44.5% were robotic, 52.9% were open. What's interesting is they were just looking at overall complications, minimally invasive radical prostatectomy, both robotic and open. And they looked at any perioperative complication, cardiac, genital urinary, miscellaneous medical, surgical, respiratory, death. They looked at blood transfusions. And in every case, it was statistically significant that in the robotic series, it was much better than open. They also looked at late complications, and this was the same again where there was a benefit to minimally invasive. They looked at anastomotic strictures, ureteral complications, and lymphocele. So I know it doesn't prove that much, but it suggests. And so the question is, what is the effective technology, namely the robot, in doing a prostatectomy? Potentially magnification and visual guidance allows for improved understanding of the nuances of the surgical technique, and the robotic manipulator improves the surgical performance. So this is a Gaussian distribution curve with a standard deviation of 1. We're all familiar to this curve because we all took organic chemistry and know where our scores fell on this curve in college. So unfortunately, surgical skill follows the same distribution. So our goal should be, as surgeons and innovators, we should be moving that curve to the right, and we should be narrowing the variability. And the question is, how can we do that? And can robotics and technology do that? And I would propose possibly yes. So that's how skill can be impacted by technology. How can judgment be impacted by technology? So this is an article that was published in The Atlantic in March of 2013. It's a great article if you get a chance to read it, and it was titled "The Robot Will See You Now." And they were talking about the IBM Watson computer and its use for complex decision making. And it was applying new ways of accumulating, processing, and applying data. And it really described a disruptive force, which is how something is done and who does it. A great example of a disruptive force is an ATM. So prior to ATMs, you can only deposit or, God bless you, withdraw money when the bank was open and there was a teller present. Now you can do it 24/7, 7 days a week. So the Watson was able to improve efficiencies and reduce treatment errors. Impressively, at the time, which is probably even faster now, it was able to process 60 million pages of text per second. So now the question is, how can we use this to impact judgment? In order to get into the area of AI, what I want to do is define for you a couple of terminologies that you hear a lot, but I'm not sure most people understand. One is big data, and the other is machine learning. So what is big data? Large volume of high velocity, complex, and variable data that requires advanced techniques and technologies to enable the capture, storage, distribution, management, and analysis of the information. They classically call the 4 V's of big data: volume, velocity, variety, and veracity. Volume, so think about PubMed. Think about how many articles are published in PubMed. It's just an amazing volume of data. Velocity, how many new articles are published in PubMed per day? That's the velocity. Variety, that's when you're talking about different types of data. So let's think of the medical record, EPIC. You have fields that you can fill in, name, age, date of birth, but then you also have just text. You have path reports and radiology. So those are different types of data sets. And then veracity has to do with the noise or missing data. So machine learning. So data, if you have a data set, it means nothing. So data by themselves is useless, but we want to transform that data into knowledge. And it's the algorithms of machine learning that will be transformative. You also have to understand that this is different than how we've normally thought. We do a lot of deductive thinking, so it's hypothesis driven. Machine learning is inductive, so it's generalizations from specific observations. So a machine learning algorithm, so the scientists behind this, they write algorithms that produce programs. That program does a task. So the program is derived from examples of the task, so they have a training data set. And the machine learning trains an algorithm so that it can learn how to do something. Training involves feeding huge amounts of data and allowing the algorithm to adjust and improve. So here's an example, speech recognition. What does machine learning do, and how does Siri work? Well, what the algorithm does is the algorithm basically tries to create a program based on a training data set. The training data set is a series of inputs and outputs. For speech, the input is speech, the output is the written word. So you can imagine you can generate a huge data set. As a human, you can write down every word you know, you say the word, you link it to the actual written word. You put that data into a machine learning algorithm, and then what it tries to do is to generate the program that makes the link between the two. That's speech recognition. It's unbelievably powerful. The other area that you can do this is in visual recognition. So if I want to train a computer to basically be able to depict a dog, a picture of a dog, I take 1,000 pictures of a dog from the internet. I have to go ahead and tag them and say, this is a dog, this is not a dog. You then feed that information into the algorithm, and a program will be generated that will actually teach the computer to identify a picture of a dog, and that exists. So the question I have for you is, which one's the Chihuahua and which one's the muffin? So it's amazing, but a computer can probably do this much better than you can and a lot faster. So big data. The 4 V's that we talked about are both opportunities and challenges for machine learning. What are the success stories? So when you have a data set that is very large and it's accumulating very quickly, that's where machine learning can be very helpful. An area is medical imaging. So this is an article that talks about the development and validation of a deep learning algorithm for detection of diabetic retinopathy and retinal fundus photographs. So as I just mentioned, you can teach a computer to look at a picture and give you a diagnosis. So pathology and radiology are ideal subspecialties for machine learning applications. There are already many companies out there in the world that are offering products that are beginning to develop for radiologic reads and pathologic reads. What are the challenges for machine learning? That's when you have variety. You have a lot of different types of data, and there's a lot of veracity, potentially noise or missing data. What's an example of that? Personalized medicine. Huge amount of variety, a huge amount of veracity. So look at what we have here. We have clinical notes, drugs, procedures, physiologic measurements, laboratory data. Within the clinical notes, some of the stuff may be structured, meaning you can interrogate it. Some may just be text. Some things may just be a picture. So that's a lot of variety. And within this, there's a lot of noise. There's a lot of missing data. So the solutions for personalized medicine will be driven by addressing variety and veracity. Variety is how do we integrate many types of data to help make decisions tailored to the individual, and veracity, how do we handle data sparsity, how do we handle noise in the data set. Here's where we have failed as an area of a scientific discipline, medicine. I think there's a lot of other technologies that are further ahead of us. A limitation, and the reason for that is there's inadequate training data sets in medicine. Here's an article that was published by Google in 2009, The Unreasonable Effectiveness of Data, and their conclusion was that the algorithms for machine learning require millions of observations to reach acceptable performance levels. And as an example of where we are woefully lacking is here's the Cancer Genome Atlas, so the TCGA, for the mutations for clear cell renal cell carcinoma. This data set is only 385 renal cell carcinomas. In order to start using machine learning in pathology and radiology, you need thousands, if not 10,000s of examples. So even for MRI, multiparametric MRI of the prostate, we actually don't have enough imaging in order to be able to use machine learning for diagnosis of prostate cancer in multiparametric MRI. So the failure of big data in the life sciences, we lack volume, but where we've really fallen off is we have too much variety. If you think about it, Epic is a horrible product for us because it's not very interrogatable. Had that been designed knowing where we need to be today, we would actually, our pathology, our radiology, would have been implemented or put into the process much better. So we have, unfortunately, very little structured data, so data cells. We have too much unstructured data, text and imaging, and so we have to correct that as we move forward. But if we can, the application of machine learning in medicine is amazing. Potentially allows for the analysis of complex, multidimensional data, and we're accumulating that data as we speak. Genomics, proteomics, pathology, radiology, physiologic parameters. So only machine learning is going to allow cross-referencing of that. A human can't possibly do this. So disruption of medicine by machine learning. I think we'll be able to improve prognostic accuracy, predicting mortality in cancer patients, enhance interpretation of digitized images, and improve diagnostic accuracy. Technology is going to disrupt this for us. Google and Apple already have huge divisions in medicine. And just to give you an example, look at this contact lens by Google. It's a soft contact lens. It has a sensor that can detect glucose in tears. It has a chip and an antenna that receives power and sends info. So it actually can monitor your glucose via your tears and send it to your handheld device. This stuff is what's going to help this technology. This will increase the volume of data that we have and decrease the variability of data. Here's another company, take a look at if you get a moment. It's called Babylon Health. So what it is, it's an AI platform for the diagnosis of over 80% of conditions diagnosed by primary care doctors. And it's actually a chatbot, which means that you interact with the AI via your phone by either speech or text. So it starts out, "Hi Alex, how can I help you?" "Hi Babylon, I have a bad headache and I'm not sure what to do." "No problem, I just need to ask a few questions." And it'll actually walk you through and give you a diagnosis. Here again, based out of London, this has been adopted by the NHS and it's being rolled out. And what they do is it helps create a differential diagnosis, and then it immediately connects you to a primary care doctor for a visit, not in person, and then after that interaction decides whether you actually have to see a primary care doctor. So we're already there. Healthcare is in a crisis. We have to improve outcomes, decrease costs. We can improve skill, embrace advanced technologies, minimize surgeon-physician variability. We can enhance judgment. We have to focus on more structured data sets than unstructured. And we should be willing and able to employ machine learning to identify learned algorithms for radiologic and pathologic interpretations and medical diagnoses. I did a PubMed search yesterday, and I put in AI and robotics. 39 references came up. So the future of surgery is robots and artificial intelligence. The future is inevitable. Thank you.